And of course, as we've been repeatedly saying, unfortunately, none of the squint surgeons have any financial disclosure to make. The aims of treatment, what is the aim? You face a child of nystagmus, you've diagnosed, you know your options are limited, but what is your aim of treatment? You need to stabilize the eyes so that there is some improvement of visual acuity, decrease the occulopsia if the patient has occulopsia, shift the null zone to the primary position, which in most cases, this treatment is limited to patients with manifest nystagmus. Manifest latent nystagmus and head turn towards the side of fixing eye may also benefit to a certain extent. How do you improve vision? What is the effect of surgery that you're having? The aim is to increase the breadth of the null zone. The null zone is that area between less than 4 degrees from the point of central fixation, the duration for which the eye is stable and is looking at the object of regard. So it's only during that period that the brain is able to take cognizance of the object that the eye is trying to see. Subsequent to that, before and after, it's off the target of regard, and the child or the person is not seeing. So the aim is to increase that period of foveation time that is there. Just like this, in this case, you can see on the top, you can see that above the period that is between that 0 to 4 degree is much less, and after a supramaximal recession, the nystagmus is still there. It's not that you have completely eliminated the nystagmus, but that period of the time during which the eye is within 0 to 4 degrees of the fixing target has increased. So this is the basis of your intervention for nystagmus surgery. Quickly run through major management, because the other things are equally, if not more important: optical devices, occlusion, medical treatment, acupuncture, auditory biofeedback, botulinum toxin. The optical correction is most important because it's the single most important therapeutic intervention we can do in patients of nystagmus. The retinoscopy should be done in the null position if present, and over-minus lenses can be used to stimulate accommodation and decrease the intensity of the nystagmus. Amblyopia therapy is very important. In the past, latent nystagmus was considered a contraindication to conventional occlusion. However, now we feel that although there may be an increase in the initial nystagmus, but with the improvement of visual acuity with the occlusion therapy or amblyopia therapy, there would be an improvement in the latent component of the nystagmus. Prisms can be used to simulate convergence by base out prisms, or else you can even give a pre-operative prisms to check the effect of your head posture surgery that you would be doing. You can do the you can induce fusional convergence and see whether the person was going to be better after the surgery, base out your lateral rectus recession that you're planning, medial rectus recession that you're planning, so that you can induce a little bit of convergence. But it's very important to do this test before you plan surgery, because the patient may unfortunately start developing intractable diplopia after surgery if you have not done this. In the pre-op evaluation, in a patient with a face turn, the prisms are inserted with the apex in the direction of gaze, that is the base towards the face turn, and this can help us to predict the results of surgery and help us to estimate the amount of surgical correction or the dose which we have to plan. Medical management, there is a fair amount of interest in medical management, particularly in secondary nystagmus or neurological ones associated with neurological disorders. However, for infantile nystagmus syndrome, as of now, drug intervention or pharmacological intervention has not found to be very beneficial in these patients. Botulinum toxin is one of the options. The unfortunate problem with that is, of course, that it is a short-acting procedure. It does not last so long. So it is of definite importance in patients who have a temporary nystagmus, say due to a space-occupying lesion or some other associated systemic problem which has given rise to a nystagmus. They may definitely benefit from this short-term advantage of botulinum toxin that may help you to stabilize the eye. But again, for cases of infantile nystagmus syndrome, it may not be such a useful option. The alternate therapy exists in the form of contact lenses, auditory biofeedback, acupuncture. Contact lenses in higher myopes help to keep the image on the fovea, so that the contact lens or the refractive correction moves with the nystagmus or the eye, and therefore keeps the fixing target on the eye and helps, whereas in spectacles it can be a problem. And of course, the tactical biofeedback that contact lenses can help to dampen the nystagmus. although it's not such effective in the long term. Auditory biofeedback is another one of the procedures that tends to reinforce the ocular motor system by auditory stimulus. It is unfortunately also transient. Acupuncture has been tried in one of the studies at the center, and although during the procedure of acupuncture it was definitely gratifying for the patients and you could objectively see a reduction in the nystagmus patterns, but after the removal of the needles and long term, the nystagmus tended to come back. Important to know that where you are intervening, and many of these things are exclusive of each other, so you have to try and add as many interventions as possible to improve it. Surgically, you can induce a convergence so that you can dampen the nystagmus. You can shift the null if there is a presence of a null, or reduce the amplitude by procedures. To induce convergence, you can do bimedial recessions. It's important that normal binocular vision is good, and you can even try it with prisms preoperatively to ensure that the results are as per what you want. The correction of face turn, you have numerous alternatives: the Kessenbaum procedure, the Anderson's, and the augmented Anderson's. And dampening of the intensity in the primary gaze, you have supramaximal recessions of all four recti and the four recti tenotomies by Hertel de Loso. In the Kestenbaum's device surgery, all four recti were done, which were initially advocated to be 5 mm for all recti, and Anderson's advocated only recessions, and Goto advocated resections. Park's modification was that lesser amount of recessions for medial recti compared to lateral rectus, as we know that the medial recti have a greater effect as compared to the lateral rectus, so advocated the 5, 6, 7, 8 plan for face turn surgery. The augmented Anderson's procedure was planned where only a large amount of recession is done on the yoke muscles, and the advantage of this is that if you have undercorrection or recurrence of face turn after maximal recessions, you can tackle the other muscles and do resections as required. Or if you have inadvertently operated on a periodic alternating nystagmus, you could recess the other yoke muscles and do an all four recti recessions to get the null point back in primary position. So for a face turn to the left, in the right eye, you would do the lateral rectus recession about 12 millimeters and the medial rectus recession about 9 to 10 millimeters. We had done a study on the augmented Anderson's procedure and using 9 mm recession on the medial rectus and 12 mm on the lateral rectus, and the effect was pretty gratifying. A good correction of the face turn was observed with very few side effects. Only a mild limitation of movement was observed, and like I said, can easily be converted to all four recti recessions if you inadvertently operate on a pan. This you can see the electronystagmography of the patient, the preoperative on the up and the post-op in the lower part. You can see that there is a definite improvement in the ENG curves. And again, another patient with a face turn to the right, which improved after the augmented Anderson's procedure. Again, showing on the ENG the improvement. The null which was on the left side has now shifted onto the primary gaze. So although there is some nystagmus, there is a definite dampening of the nystagmus. Video. Just a small video of a pre-post. Not running? We can go up. The previous one is not running. This is just the corrected head posture. The previous one not running. Just wanted to show that with time, sometimes a child will present to you without a head posture, but as he reads down the Snellen's chart or give him a visually demanding task, you can see that progressively the head posture manifests itself. You can do correct for vertical head postures, management of chin up or chin down. You can do the vertical recti recession resections. It becomes a problem if there is an associated horizontal squint, because then you would have to operate on more than two muscles in the either eye. But you can start off with doing recessions and correction of the horizontal squint and stage the resection procedure at a later date. The head tilts, oblique head postures and head tilts because of torsional nystagmus can be done either vertical shifting of the horizontal muscles or horizontal shift of vertical muscles, or preferably the oblique muscle surgeries. Selective advancement and recession of the anterior fibers of the oblique muscles is, although technically more difficult, but the results can be more gratifying, as we had done in a case like this, where pre and post we had done the, you can see the correction of the head tilt with operating on the oblique muscles. Decreasing the amplitude of nystagmus when there is no null, or there is the minimum amplitude is in the primary gaze. You can do all 4 recti recessions and the Hertel-Deloso procedure. Again, all 4 recti recessions, we do lateral recti recessions of 12 mm on both eyes and medial recti recessions of 9 mm. This places them somewhat close to retroequatorially, dampening the amount without reducing the amount of excursion that is possible in the lateral rectus. It is cosmetically gives a good result. Satisfaction is good. There may be a little improvement in visual acuity, although it may not be translated in the long run. And however, the caution is that there is always that risk of consecutive exotropia that you should be aware of. The 4 recti tenotomy has been now fairly repeatedly published by Hertel-Deloso, and it just works that you disinsert the muscle and reinsert in its own place, and works by interrupting the proprioceptive afferents from the extraocular muscle. And at our center we had done a study where the outcomes were similar as far as 4 recti recessions and the Hertel-Deloso procedure was concerned. So you could possibly do either when you are doing that. So when you are planning for nystagmus blockade, we have discussed a case earlier where you would prefer to do medial recti recessions along with the posterior fixation suture, so that you can correct for the blockade along with the strabismus. And in latent manifest nystagmus, if the squinting eye with the latent nystagmus has poor vision, you may just correct the squint in the non-fixing eye or the non-dominant eye, or you can do if alternately fixing eye is there, you can do a bimedial recession to get alignment as well as dampen the nystagmus to an extent. Again, this case we just needed to do the right eye, which was amblyopic, and do the correction. In nystagmus, we learn that there are a lot of things we still need to do before we can get good satisfaction in our patients. Thank you.